thanks for everyone for joining us on the webinar today. So the topic today is about rare tumours and trying to get a bit of an introduction to some of the things that, particularly as trainees, we don't really see very often. So I think we've got two really excellent talks this evening. One is on thymic cancers and thymic tumours, and one is on gestational trophoblastic disease, which are obviously things that we don't see very often. And I think certainly I know one or two times I have seen these when I've been on call, I've been a bit unsure about what treatment options there are and how to manage them. So I think this will be really useful, at least, and hopefully for a lot of the audience. So we've got two talks and then two trainee case presentations. The first talk is by Dr. David Gilligan. So Dr. Gilligan is a consultant clinical oncologist at Cambridge University Hospitals and the Royal Papworth. He trained in oncology at the Christie and at the Royal Marsden, and his main interests are in thoracic oncology. Amongst many other things, he's a trustee of the Roy Castle Lung Cancer Foundation and was a member of the NCRI Lung Cancer Studies Group from 2016 to 2019. So an excellent person to come and introduce us to thymic cancers. If you have any questions, if you could just put them through the chat function and we'll ask them at the end. Otherwise, I'll hand over to Dr. Gilligan to talk about his area of expertise.
Okay, thanks very much, Richard, and thank you to the ACP's trainees for inviting me. I'm going to try and share my screen. Well, next slide. My disclosures, next slide. So I'm going to talk about four things and finish off with some case presentations. So you can see we'll talk about the epidemiology, trying to sort of work out stage and pathology, which can freak people out a bit, talk about some things that are unique about thymomas, and really concentrate on the systemic management, although touching on other forms of management, and as I say, some case studies. Next slide. So we're talking about rare tumours, and they are rare, but they're becoming more common. And certainly the published rates, if you look in journals, of say 2 to 3 cases per million is probably an underestimate. And there may be a number of reasons for that. This is a piece of work I did a few years ago with NHS England, and the graph is the cases in England, and for some of the data I'm going to show you, the denominator is different, so just to be aware. But and the different color blocks are the different ICD codes that have been used. The one that should be used is C37, but you can see that that is an upward trend, and that in 2016 there were over 250, about 270 cases. And if you, that's in 2016, and if you apply that to the UK, that's probably about 300 new cases a year. But I think we're looking at probably an incidence of much more than that now. Next slide. And one of the reasons is that we're doing more CT scans. So on the right, you can see that from just as NHS England data set, we're doing, and as you're all aware, we do far more CT scans than we did, say, 10 years ago. And a lot of thymomas are incidental findings, and you can see highlighted there on the left, there's just a small anterior mediastinal mass. Someone might have had a CT scan for chest pain or CTPA to exclude pulmonary embolus or for some other reason, and they find something abnormal in the anterior mediastinum, which is where thymomas sit, and therefore we're seeing more of them. Next slide. And again, this is just data to support that we're seeing more. This is again some data from audits. This is the Society of Cardiothoracic Surgeons report, and you can see from the red arrows pointing that the number of thymectomies for thymoma are increasing. It's a different baseline because this is UK and Ireland surgical data, not the England data that I showed you, because they're looking at different populations. Next slide. And then just to update that a little bit, this is the same organization's data for 2017-18, which is the most recent that I could find. And you can see that 334 thymectomies were done in that period. And if you're taking the ones that are inoperable, which are a lesser number, you can see that we're on our way to 4 and possibly 500. Just a word on surgical data. I think the one thing I will say in this talk is that by and large, the majority of thymomas and thymic cancers are operable, certainly thymomas, and will never need any other additional treatment. So surgery is the mainstay of treatment. Surgical practice has moved from, and you can see there the majority of cases in 2017-18 were open cases with a minority of VATS and RATs. That's changed now. Virtually all of them are done by VATS or robotic RATS surgery. And so quite a lot of them are done by a minimally invasive sub-xiphoid approach, just going underneath the sternum. So that's changing, but I haven't got any hard data from the cardiothoracic surgeons to give you that verbatim. Next slide. So if we go on to staging, when I started with thymoma, staging was easy. It was the Masaoka or Masaoka-Koga staging system, which you can see on the left here. And really it was tumor within a capsule, poking out of the capsule, going into something else, or stage 4 disease, which was pleural or pericardial disease with drop metastasis. And then more unusually, particularly with thymomas, but not thymic cancers, spread outside the thorax. More recently, we've been moving over to a TNM staging, which brings it into, obviously, line with other tumors that we're much more familiar with, and does reflect outcomes better, but it is a little bit more complicated. At the bottom of that table on the right, you can see the stage grouping, which is different from the Masaoka-Koga staging system. And the most important thing is that a stage in the new system, a stage 1 tumor, T1, N0, M0, could have been in categories 1, 2A, 2B, which is just a tumor poking out of the capsule, or even sometimes 3. However, as I said earlier, the vast majority of them are early stage disease. They are T1 tumors, and they have a very good prognosis. And so we're just in a state of transition now in terms of working out what the best treatment is on new, or really adjusting the staging systems between Masaoka-Koga and TNM. Next slide. This is slightly out of order, but the one thing that maybe sets thymomas particularly apart is that they are very commonly associated with paraneoplastic type syndromes. The most common, which I've highlighted or bold, is myasthenia gravis, and I'll show you a slide that the percentage that may have myasthenia gravis. So as well as an incidental finding, patients with thymomas may present through neurology who've been diagnosed with myasthenia gravis, and they'll have, as part of their workup post-diagnosis, they'll have a CT scan of their thorax, which may show a thymic tumor. Other ones are polymyositis, limbic encephalitis, Morvan syndrome, all much rarer. In the hematology spectrum, red cell aplasia is something that you can see from time to time. And a lot of patients have some sort of immune paresis, such as Good syndrome, which is hypogammaglobulinemia associated with these tumors and can be quite troublesome. And actually, we'll come on to this, but it may not be the thymoma itself, the actual bulk of the tumor, which is the problem. Sometimes the problem is managing these very difficult paraneoplastic syndromes. Next slide. If we look at the pathology, so pathology is different from stage, and there are different thymic histotypes ranging from A through AB, B1, B2, B3, and actually stage and type C, which is a thymic carcinoma. And these are, I won't go into what they look like down the microscope. The pathologists at the MDT will give you some indication of this. Sometimes you can get mixed tumors with bits of one and bits of the other. But if you look at the diagram on the right, what you'll see is that you'll see that in yellow, the stage 1 tumors tend to be in the A, B, and B1. So they're the more sort of benign type. And then you've got a sort of phased transition across stage 2, 3, and 4 to the more aggressive types of B1, B2, B3. And not on this diagram is the thymic cancer. But so type B3 is also called well-differentiated thymic carcinoma. So you can see that there is a spectrum of biological behavior going from A through to B3 and C. And obviously that is reflected in the stage. So the more benign ones at the end of the spectrum tend to be the stage AAB type, AAB types in that are early stage 1 tumors that will be resected and no other treatment is needed. Next slide. And overall, you can see that thymic tumors do have a good prognosis. If you've got a stage 1 tumor, then you'll see that the overall survival rates and indeed the tumor-specific survival rates are really quite amazing. And even for stage 4 disease, you've got survivorship going out for many years, up to 50% or more. So people with advanced disease, unlike, say, some other malignancies, and particularly thoracic malignancies, which tend to be managed by the same people as managing thymomas, they are a different cohort. They're a very different population and behave different ways. Next slide. So this is just to remind you that thymoma is not lung cancer, and these 2 CT images are from a patient who was diagnosed in 2007. And you can see that you can be diagnosed with a considerable bulk of disease. You can see that the tumor is occupying and putting pressure on structures in the mediastinum. But because they grow quite slowly, there is a lot of compensation, and people can live with really quite terrible bulk of disease and never cease to be amazed that people are walking around relatively asymptomatic with disease that looks quite horrendous. And the scan on the right just shows that 4 years later, the more advancement of disease with the classic pleural metastasis, but the patient was still reasonably well. Unfortunately, the patient sadly died, I think, in 2020, but was diagnosed in 2007, so survived 13 years with quite a considerable bulk of disease. Next slide. So thymic MDTs may not be a common thing because of the rarity, but it's important that if you have even if you have a virtual thymic MDT, people that you can call on, that you do have the extended MDT, and the normal groups in grey are very important, but there will be an extended MDT of people who you will need to consult for maybe some of these paraneoplastic syndromes, in particular neurologists, hematologists, and immunologists. Next slide. So when it comes to management, as I said, the majority of disease is early stage resected, and actually not many people require adjuvant treatment. Now, on the left is a diagram which is taken from the ESMO guidelines, and these are very, very good, and I will reference them at the end of my talk in a slide. They are easy to follow, and I think if you use these, you can't go far wrong. But really what this is saying is that after resection of a thymoma, if it's R0, completely excised, in almost all cases, you don't need any other treatment. If it's a thymic carcinoma, you do need to consider some post-operative treatment. Next slide. And if we move on to advanced disease, which may be more pertinent for people online, you'll see that on the right there is a slide again showing an anterior mediastinal mass and typical pleural deposits. And usually in that situation, the aim is to give chemotherapy, primary chemotherapy, to see if a tumour can become resectable, but it's important to discuss them at an MDT with surgeons. Most MDTs that discuss these are the lung cancer MDTs, as I said earlier. Thymic MDTs are few and far between. A number of places do have them, bigger centres like Guy's, Manchester, and actually I think Leeds has one, but it's not a big general MDT. It's an oncology MDT by the oncologists who are interested in thymoma. So most people will discuss them within the confines of a lung cancer MDT. But basically, the guiding principle is chemotherapy to downstage, sometimes chemoradiotherapy, and then a view to see if they're resectable, and then follow up. Next slide. So chemotherapy regimes, they've been around for a long time. The top two are probably the main two primary ones, particularly for thymoma. So cyclophosphamide, doxorubicin, and cisplatin, or platinum, carboplatin, cisplatin, and etoposide. And both of those have about a 50% response rate when given in the primary setting for thymomas. For thymic carcinoma, you can use those regimes, but also carboplatin and paclitaxel can be very effective. And so there is a choice, and you might want to choose a particular drug ranging on the comorbidities. I'd say that they're all quite heavy-duty regimes, but they are effective and normally between 4 and 6 cycles, depending on how people are tolerating them. There have been a lot of phase 2 studies looking at other chemotherapy regimes, and I've listed a couple of them there with modest response rates, such as capecitabine and gemcitabine, or single agent pemetrexed, but they tend to be used in subsequent lines of treatment. Next slide. In looking beyond chemotherapy, there has been some work with tyrosine kinase inhibitors, particularly, or historically anyway. Sunitinib has been used, and this is a phase 2 study from a few years ago looking at it, giving a sort of renal type dose of sunitinib. And you can see from the waterfall plots, and the one on the left is a thymic, for those for thymic carcinoma, and the one on the right for thymoma. There is a modest response rate, particularly for thymic carcinoma, but it is quite a toxic regime, and a lot of people, a fifth of the people had the treatment stopped for toxicity. So I'll come back to TKIs a little bit later. We may be moving on a little bit with TKIs, but it's with all rare tumors, it's not licensed, and therefore to say to a patient, I can give you a TKI, is very difficult, because these are not funded and they're not NICE approved, and it's something which is a very difficult situation, because they're never likely to be based on the paucity of evidence or evidence from phase 2 studies. Next slide. Also used more in thymomas than thymic cancers, and has been used, have been somatostatin analogues, because some thymomas do express somatostatin, and for those that do, and here is an example of a patient with some modest uptake. You never see very great uptake, but you can see modest uptake, and they've also some of the more eagle eye will spot an SVC stent in situ in this patient. But if you can arrange some sort of octiotride scintigraphy or PET, then you can work out who might respond to somatostatin analogues, which are usually very well tolerated. Next slide. There have been a couple of studies, again, phase 2 studies. The main one was from Indiana on the left, which gave octiotride. You have to give that obviously subcutaneously, but they did see a response rate, particularly when given with steroids. And then also there was a German study looking at neoadjuvant in unresectable, and very small study, 17 patients, but they had a long-acting analog plus prednisolone for 24 weeks, and just over half of them became resectable. So it is also, it's worth looking at, but in my experience, the majority of people do not take up octreotide. Next slide. Now, the one thing that is quite fashionable with most tumours is immunotherapy. But one thing that you have to be aware of is that there is, or there's certainly been reported, a increased rate of immune-related adverse events with immunotherapy. And that kind of ties in with the immune type, the biology that thymic or thymomas have. So any study that's been done, by and large, excludes patients with thymoma, apart from the B3 thymoma, which is the well-differentiated thymic carcinoma, and or anyone with an immune-related condition, be that, say, myositis or myasthenia. The trials that have been done have been, those patients have been excluded from them. But there have been some response rates, and I'll show you one in my case study. There was a single center study with pembrolizumab, published in Lancet Oncology, with Giuseppe Giacconi, with a 22.5% response rate, but they did have 15% severe toxicity. More recently, EORTC have done their Nivothyme study, which was in relapsed disease and was reported at ESMO a couple of years ago, at least in part. Now, the study did show some response with progression-free survival rate at 6 months of 35%, but it didn't reach its primary objective. And so that study was extended to include ipilimumab together with nivolumab. Now, that's just closed. It was only open in 2 centres in the UK, the Marsden and the Christie, and there was quite a hiccup with COVID and other issues in implementing the study in the UK, and possibly Brexit as well. So that study has been partially reported, but not completely reported, but is now closed and is not recruiting anymore. Next slide. One recent study is the Caveat study, which is interesting in that it's giving immunotherapy in the form of avelumab plus TKI, axitinib, similar again to a renal type regime. And that has produced some good responses, but also some quite interesting toxicity data. And it appears to be a bit less toxic. I mean, maybe with the evolution of better TKIs approaching where we can give this treatment. Again, we can't give it as a it's not licensed for treatment, and this was only published in the Lancet Oncology at the end of last year. But again, you can see it's unresectable or metastatic type B3 thymomas or thymic cancers, not anything less advanced or less of a lesser type, or lesser pathological type. But you can see from both the waterfall plot and the swimmer chart that there are some good and enduring responses, which are quite promising. The other thing I'll say before I go on to the case studies is that sometimes not doing anything is a good idea. I showed you slides way back of people with very extensive disease, and it's important to explain to people, although they're desperate for more and more treatment sometimes, that living with the disease, with an extensive bulk of disease, is actually the best thing to do, and you have a better quality of life if you're not having a treatment that is likely to give you toxicity. So particularly with the more advanced thymomas of, say, B1 and B2 type, that is a very real option. Next slide. One other thing is, which is applicable to all of the thymomas and thymic cancers, is radiotherapy. In a palliative setting, can be very effective. And if it was a drug, we would be and it would be probably licensed for it. These are two examples, one on the right and one on the left, one on the right, both of them showing pre and post radiotherapy images with quite a marked degree of improvement. And the advantage of that is that is not restricted in its use. You can ask your clinical oncologist to see if some radiotherapy might be good. You don't have to treat the whole tumor, you just have to treat the bit that you're worried about. And a modest palliative dose of something like 30 gray and 10 fractions, which I think is what both of these patients had, was effective. Next slide. So I'm just going to briefly end with two case studies, one of a thymoma and one with the thymic carcinoma. So first case is a 29-year-old teacher who presented to me almost 10 years ago. He was very, very systemically unwell. He'd lost a lot of weight. He was performance status 3, and he was also found at the same time to have a Klebsiella pneumonia, which is important. He had a biopsy and he had a mixed B1, B2 thymoma, stage 4A, and you can see from the top CT image, it was a pretty big, nasty, extensive tumor. He wasn't well enough to have chemotherapy, and we treated his pneumonia, but also we gave him steroids of a dose of 50 milligrams a day of prednisolone. And the important thing there is that B1 thymomas have a very large number of lymphocytes, so you can actually get quite a marked response just on steroids. And the middle slide, which is the 13th of October 13, shows not after chemotherapy, but that's after a course of steroids. He improved in October of that year, and then went on to have 6 cycles of CAP chemotherapy with a good partial response, and went on to have resection. Next slide. And you can see there that 3 or 4 years later, you can see that there is evidence of surgery, but he didn't really have any more oncological treatment after that and was followed up for a number of years. But what did happen, and I mentioned this earlier, is that he developed some of the paraneoplastic syndromes that I've mentioned. He developed a very nasty ocular myasthenia, which needed treatment with mycophenolate and prednisolone, and in fact an eye patch. And then he developed a secondary immunodeficiency, although he may have had a degree of immune paresis with his Klebsiella pneumonia, with bronchiectasis, and was under the care of the chest physicians and the immunologists, having IG infusions, and then developed inflammatory myositis a few years after that. And you can see that his last CT scan in 2019 showed not a lot of pleural disease, but there is a collapse of the left lower lobe due to infection and mucoid plugging. So, and he sadly died during COVID in August 2020. So he lived with 7 years, but the only oncological treatment he had, which kept most of his disease under control, he had some very minor recurrence at the end, was his chemotherapy. Next slide. Now, this is a case of thymic cancer. So this was a 56-year-old lady, never smoked. She'd had DCIS a few years previously, but she had noticed that she'd been coughing and increasing breathless in retrospect for up to a year, and had a recent chest infection. And it was that sparked the chest X-ray and then the CT scan that you see there on the left. And it was suspected that she had a lymphoma, but the biopsy actually showed she had a thymic carcinoma. Next slide. So she went on to chemotherapy with carboplatin and paclitaxel. She had 6 cycles, but we had to reduce the dose because she had quite significant peripheral neuropathy. And we discussed her MDT, and you can see, not surprisingly, because of the mediastinal invasion, that she remained inoperable. The surgeons felt that they couldn't operate. So we proceeded to radiotherapy. Next slide. And this is in June of 2020, after radiotherapy. We did attempt to do a radical dose, but it wasn't possible. We couldn't get the dose in safely. So she had a palliative dose of 36 gray and 12 fractions, which is what we use in high-dose palliative radiotherapy for, or is one of the ones that we use for treatment of lung cancer palliative radiotherapy. So she went on to have that and tolerated it reasonably well. Next slide. And then about 9 months later, she had a CT scan which showed progression in her right parasternal area. She was still quite well, had some mild chest pain, and I referred her for the Nevothyme study, which was open at that point, but it wasn't open in the UK. And so what I was able to get her was some compassionate use nivolumab, based on the fact that she would have been suitable for Nevothyme had it been open. And so Bristol Myers, who make the drug, were willing to supply her with compassionate use nivolumab. Next slide. And this is her scan from the end of last year. She's having another one almost as we speak. She's had 24 cycles of, or nearly 24 cycles of nivolumab, which has been very well tolerated, and she remains well. And you can see there that there's very little disease, just a sort of remnant of anterior mediastinal thickening. So some patients, not all by any means, do respond well to immunotherapy. She's had no immune toxicity. So she's a very good example of someone who's benefited from that. And we've managed to get her treatment through a compassionate access program. But of course, I have treated other people with nivolumab and it hasn't been as successful. So just to end off, last slide, please. This is where you might get information that you might find useful on thymic tumours. The top is the Annals of Oncology supplement, which is the ESMO guidelines, which I mentioned earlier, and some extracts in my slides. And as I say, they're very good, they're very usable. Below that is a more recent guideline, which has come out in the Journal of Thoracic Oncology from a Canadian group. It's good in that it updates the guidelines to include the TNM classification and some other literature review, because obviously it's the ESMO guidelines were 2015. So it's a bit updated, but I have to say it's a little bit of a turgid read, the way that it's written. But nevertheless, if you're prepared to go through it, you will get some good information. Other sources of information, BTOG, the International Thymic Malignancy Interest Group, look on their website, and also Thymic UK, which is thymic.org.uk, I think, which is a patient advocacy group and support group. And it's quite helpful, I think, to signpost your patients to that website, because a lot of them feel particularly lost and they say, well, no one knows anything about my tumor. How can I speak to people who know about it? And this is a group that's been on the go now for 4 or 5 years. And I think a lot of people will find find it very helpful and very supportive. So that's just some information that you can go to if you want to explore more. Thank you very much.
Brilliant. Thanks very much, Dr. Gilligan. That was really interesting for me and hopefully for the rest of the audience. I don't know if there's anyone that has any questions. I can't see any in the chat, but if anyone would like to ask any questions, please feel free to put it through the chat function. In the meantime, we do also have a case presentation about thymic carcinoma. So perhaps whilst we're waiting for any questions, we can get Dr. Palvai to present his case. Is that all right, Dr. Palvai?
Yeah, sure. Thank you. Thank you.
A trainee currently in the east of England, graduated in 2006, and then took a slightly roundabout route to getting to where he is today by being a clinical trials manager for 9 years, but came back to clinical medicine and is now a medical oncologist. And he's going to present his case on, as you can see, anterior mediastinal mass. Yeah.
Thank you, Richard, and thanks for ACP for giving me this opportunity. And thanks to Dr. Begum, who's my consultant here in Southend, and Dr. Gilligan for allowing me to give this presentation. This is most in line with Dr. Gilligan's presentation. I'll skip most of the common slides, which I have embedded in this. The title, as you see, anterior mediastinal mass with facial weakness. So this was in June 2021. 31-year-old woke up first thing in the morning with a right eyelid drop, and he was quite frightened, obviously, and went to GP with on and off diplopia and blurred vision. And the GP has referred him to ophthalmology, and the ophthalmology could not find a particular reason, then asked him to attend A&E when he was quite struggling with the diplopic symptoms. He's only 33, quite an active gentleman with multiple trauma, jumping off a bridge, broke his femur, and then later developed DVTs and pneumothorax. And he's on few medications since then. He's not known specific allergies and not having any family history of cancer. He works currently as an IT consultant. When he presented to A&E, there's a battery of tests. Obviously, there are several departments involved to find out what exactly could be the reason. And they did quite a few tests, which one of them would acetylcholine receptor antibodies. The titrations were quite high. And obviously, the CT head was normal. There is no stroke or any related neurological symptoms. However, on the CT chest abdo-pelvis, they found out an anterior mediastinal mass of 1.3, around 3 centimeters, which they further did a PET, which is a PET away 2.8 nodule was found out. Given the symptoms and with the anterior mediastinal mass, clinical diagnosis of myasthenia gravis was made, and then he was started on pyridostigmine 60 milligrams along with his steroids on a reducing regimen. Given the anterior mediastinal mass, he was referred to local lung MDT to further discuss the lesion. And usually on the CTs, what we can see different type of signals. We can fat, water, soft tissue. I just highlighted a few of these cancer-related, frequently observed anterior mediastinal masses with tumours, thymic lesions. Another talk which is germ cell tumors and lymphomas are the most common ones. And there are a few other. This particular age group, when I looked at him with data, if you look at on the right side of the slide, there's the B, anterior mediastinal tumors, especially who are in their 30s. The commonest ones is the thymomas, which this gentleman had. And during the discussion in the MDT, yes, there's an anterior mass, and he was referred to surgical opinion whether they could resect him with up-to-date pulmonary function tests. He was planned to have a thymectomy, but he was still on steroids longer than anticipated. Then they were considering him to change it to steroid-sparing agent and requested TPMT test whether they can go for azathioprine. The following month, he managed to have an open thymectomy. During the procedure, the surgeons noted a pleural hard nodule. I'll come back to this in the histology later. And the local histology was given as type B3, as we discussed. This is slightly aggressive type of thymoma, and it is invasive to the surrounding tissue, and the margin was involved when they have taken it out. And the local staging was given as R2 resection with the Mosako-Koga staging of 2B. This is just to highlight, as we know, the Mosako staging of different levels of thymoma and the myasthenia gravis frequency, especially with the B3 type. There's almost half of the people with the B3 type histology would present with myasthenia gravis symptoms. And as this is a similar slide to Dr. Gilligan presented, these are the commonest ones which we observe is red cell aplasia and Goods syndrome, or the other paraneoplastic syndromes which we observe frequently with thymomas. Once we discuss this locally, obviously it has to go to our regional MDT with the thymoma specialist. Center is the Royal Papworth Hospital, where further histology has been reviewed, and they agreed that this is a B3 type with the extensive extension into the surrounding fat and tumor with the positive resection margins. I was talking about the small nodule, which was a small lymph node which was not involved with any thymoma. So this is a B3 type with the incomplete resection, and they downstaged it to R1 resection instead of R2. The post-surgery, this gentleman was recovering well, and meantime, because of the long-term steroids, he developed central serous retinopathy that made us to changes to steroid-sparing agent. However, still he's having minimal symptoms of myasthenia gravis, but significantly improved compared to the baseline when he initially presented. I'm not going into detail with the staging as Dr. Gilligan was presenting. These are different stages of Koga staging, and now transiting into TNM classifications. And this is one of the questions I'm not sure whether we are able to do this poll. Yes, there's one. Thanks, Richard. So we have a situation where we have a gentleman who had a thymoma and he had a surgery, but we have R1 resection there. If we can poll of what you would like to do in this patient. Okay, radiotherapy alone. Yeah, that's pretty much the standard according to the various guidelines. However, we have took a slightly different path given I'm going to discuss that what we have done to this gentleman. And this is the same slide from ESMO paper where thymoma with R1 resection, any grade of Moussaka or histological type, goes to post-operative radiotherapy and then follow-up. That is 2015 paper. And after that, there was a 2019 NCI guidelines from America states that if it is stage 1 and 2, we'll go for surgery or surgery with or without post-radiotherapy. If it is stage 2, stage 3 or 4 with the operable disease, we'll go surgery and then followed by radiotherapy. Or sometimes we can give induction radiotherapy to downgrade followed by surgery and radiotherapy. This was a gentleman who had, in fact, with the new classification or even old classification, he comes under stage 2. However, he had slightly downgraded staging. However, he had some risk factors involved with his post-surgical staging. Then we had another discussion with the tertiary center with the Royal Papworth Hospital. The risk factors here incomplete resection, which is R1, and it's a B3, slightly aggressive rate with the reoccurrence rates around 10 years is around 8%. We went to the patient. We consider this as a stage 2/3 because of the transition of Moussaka grading to TNM classifications. And then we have a gentleman in front of us who had a surgery. We know that it is a microscopic disease, and we put forward to him to say, discuss with the patient to see what we would like to have. And then we have offered him adjuvant chemoradiotherapy with the intention to cure. That was the intention, but given in November, we consented for the gentleman for concomitant chemo-rad. The radiotherapy was around 50 gray in 25 fractions, slightly higher dose than what we would usually give, and 2 cycles of 3 weekly cisplatin. The chemo is not either full 100% doses. There is a reduction of doses. This gentleman tolerated his treatment relatively well. The radiotherapy guidelines from the ESMO suggest that we give around 45 to 50 for if there is a complete resection. If it is 50 to, if there is a R1 resection, we go for 50 to 54 gray. However, there is no concrete evidence to suggest that, or they are not recommending post-operative chemotherapy alone, either it is R0 or R1 resections of thymic. However, we can give in advanced stage to downgrade the disease. We can give primary or induction chemotherapy. and then followed by subsequent surgery or radiotherapy. And then we followed this gentleman after chemoradiotherapy as being tolerated the treatment well. In April 2022, this CT as a follow-up 3 months following the radical treatment. There is no evidence of reoccurrence. In August, we repeated the CT scan again. And the CT has showed some anterior mediastinal mass, suspicion of reoccurrence. And then we had to do further imaging again, which was not PET-avid. All the images has been discussed in lung MDT, and we thought that, and the decision was made because these changes are secondary to the surgery and radiotherapy. And we followed him up from then till date. That was last August, and in January this year, there was a CT chest abdo-pelvis was done. No signs of any reoccurrence. Still, the gentleman is on 5 milligrams of pred with azathioprine. The only thing is, obviously, we know with the stage 2B sarcomas, and there's a reoccurrence around 8% at 10 years. He'll be followed up regularly. So, as Dr. Gilligan discussed in detail in terms of what are the treatment options would be if he has reoccurred. Most important thing is any reoccurrence should be considered as newly diagnosed. So we would consider him all the options depending on the time of interval of the reoccurrence. Second line usually be given carbopacly, and newer agents are also there, either single agent pemetrexate or a combination of like a CAP combination chemo. And we have the new agents which Dr. Gilligan has discussed in his presentation. I think in summary, we have anterior mediastinal mass in a younger gentleman, differential diagnosis, who presents with myasthenia is around common in thymomas. These present with paraneoplastic other autoimmune disorders. The histology determines the frequency of myasthenia gravis. Treatment, obviously, we discussed different stages and depends on the stage of the disease with the treatment. So 10-year cumulative rate of reoccurrence for sarcoma grade stage 2 for this gentleman is around 8, and stage 3 if it is 29%. Given there is a quite significant difference between the stage 2 and 3, we had to take a pragmatic view and go for adding on to the chemo to his adjuvant radiotherapy as just only 2 cycles for the additional benefit. I think those are the references, and thank you.
I still don't, there's no questions come through the chat, but I just had a couple of questions for yourself and Dr. Gilligan, if you don't mind. So sort of our classical teaching is that with paraneoplastic syndromes, they get better with treatment of the cancer. Is that the case in your experience with these thymic cancers and thymomas?
Go on, Dr.
Thank you. Not necessarily, no. I mean, the classical teaching is that for myasthenia, which is the most common, if you remove the disease, you will get better control of your myasthenia. But some of the cases that I've seen, in particular one I showed you, the problems occurred when there was very little disease, and when patients had very bulky disease, they didn't have any problems. So most of it is pretty anecdotal and quite subjective, but not necessarily. And as I said, when people ask me, with the volume of disease, if they've got stage 4 disease, what are they going to die of? It's probably not the thymoma. It's probably, I've seen people, they succumb to the red cell aplasia. They've come to, another one had aplastic anemia. Someone else had overwhelming sepsis from hypogammaglobulinemia. So it's becoming increasingly clear to me that they are not dying from the thymoma itself, but from the other associated conditions.
Okay, and thanks for that. Because we've seen that, I think, in other types that the paraneoplasia doesn't necessarily track the cancer. There's a couple of other questions now that have just come through the chat. So the first is, can you clarify for thymomas, is post-operative radiotherapy beneficial or not?
Good question. As I said, if you if you've got a thymoma and you have an R0 resection, and sometimes that's quite difficult to decide. You have to discuss between the surgeon and the pathologist and yourselves, and then not necessary. The ESMO guidance, which we've showed you the slides of, does support that, as does the Canadian guidance. I think the number of, personally, the number of patients who need post-operative radiotherapy because they have an R1 resection is actually vanishingly small, but you just got to be aware that you may be giving quite a big dose to the heart in patients who are quite young, and therefore you've got to be a little bit careful. The alternative is to do close follow-up, either with CT or if they're young, MRI, to try and make sure that if they do have early recurrence, it's treated promptly. But the basic rule is thymoma R0, no post-op radiotherapy. R1 or a thymic carcinoma, consider it based on the stage and discussion in your MDT.
Thank you. And just one last question before we move on to the next topic. Do you have any indication why it is that patients still continue with a paraneoplastic syndrome even when you've had surgery and the potentially details of producing them are removed?
It's a very good question, and I'm going to put my hand up and say I don't know the answer to that. I mean, there are obviously some weird things going on with these patients immunologically that we don't really understand, and I think there's quite a potential for looking into that. It's probably it's not something which has been looked at, probably because of its relative rarity, but I think it's an area that could be useful research could be done.
Brilliant, thank you. So thanks both of you for your talks. That was really interesting. And now we're going to move quite significantly to a different topic. Something again that we don't see very often, particularly as trainees, and also I imagine most consultants won't see much in their lives, and that's gestational trophoblastic disease. So it's my pleasure to invite Professor Michael Seckl, who is a consultant at Charing Cross and an expert on gestational trophoblastic disease, which I understand only has a couple of centres in the UK, one of which is headed by Professor Seckl. So I think without further ado, I'll hand over to Professor Seckl for his hopefully excellent talk.
Fantastic. I don't have anything disclosures here. So gestational trophoblastic disease is a spectrum of placental disorders from the pre-malignant and commonest forms, which are complete and partial molar pregnancies, through to the malignant conditions of invasive mole, choriocarcinoma, and the extremely rare placental site and epithelioid trophoblastic tumours. So to put this in perspective, in the UK, we register overall 1,800 cases each year with some form of trophoblastic disease. The vast majority are molar pregnancies. 1 to 3 in 1,000 pregnancies will be molar pregnancies. And roughly speaking, half of them are complete moles and half of them are partial moles. It is well recognized that complete moles can transform in about 16% of cases into invasive mole, predominantly, or choriocarcinoma less frequently, and rarely into placental site and epithelioid trophoblastic tumors. Once you've got one form of the malignant disease, it's possible to progress into the other forms. And it is possible to develop a chorio or a placental site or epithelioid trophoblastic tumor after any type of pregnancy. So it doesn't have to have been a molar pregnancy. It could have been a term delivery, for example, or an ectopic pregnancy. About 1% of partial molar pregnancies will transform into a malignant form of the disease. And it's possible for it indeed to also give rise to chorio and to rarely to placental site and epithelioid trophoblastic tumours. So more recently, we've realized that there is a new member to the gestational trophoblastic disease spectrum, and this is something called atypical placental site nodules. So every placenta has anchors which attach it to the wall of the womb. You get to the end of the pregnancy, the baby comes out, the cord comes out, the placenta comes out, but the anchors remain in the wall of the womb. And usually they spontaneously involute in the coming weeks, but in some women, for reasons we don't understand, they persist and form placental site nodules. And some of those may show some atypical features under the microscope. If you're unfortunate enough to have one of those discovered, usually because of some irregular bleeding leading to a D&C or a hysteroscopy and biopsy, there are about 15% of women with atypical placental site nodules who will either already have a placental site trophoblastic tumor or an epithelioid trophoblastic tumor, or will subsequently go on to develop these rare cancers. So, all right, let's focus on the tumors. And the commonest form arise after molar pregnancies and typically will turn out to be an invasive molar chorea, although we will not usually rebiopsy to prove that point. The way we work this out is because the pregnancy hormone produced by this placental tissue plateaus or rises following the molar evacuation. So where disease is growing back. And so that tells you you've got malignant transformation. So to work out what sort of therapy you're going to treat these patients with, we have a scoring system. So throw away the staging system. You don't really need it. You need this scoring system to tell you what the risk is that your particular tumor is going to become resistant to one drug therapy. And that drug is typically methotrexate or actinomycin D. So a lot of this scoring system is fairly obvious. So the more HCG you have, the more points you pick up. And so if you've got 100,000 or more on the HCG, you get 4 points. If you've got lots of metastases, you get more points. If you've got metastases in difficult places to treat, you get more points. And when you basically add up the score for your patient, and if you score between 0 to 6, this tells you you've got a low risk that your trophoblastic tumor is going to become resistant to one drug therapy. If your score is 7 or above, it's high risk. And in recent years, we've realized that there is an additional group worth recognizing, which is the ultra high risk. And I'll come back to that in a bit. But let's just focus on the low risk disease, which is the vast majority of the patients that we see in the UK. Probably we treat in the UK about 140 or 150 new cases of trophoblastic tumor each year, so rare cancer. So there are some very simple things that we do when we first see the patient with their plateaued or rising HCG following the molar evacuation. And that's obviously to confirm that the HCG is plateaued or rising, because if it isn't, it's falling, you'd feel a bit of an idiot starting chemotherapy. And then there are some pretty usual blood tests that you do for anybody that you're starting on chemotherapy. And we look closely at the pelvis to get an idea of the size of the tumor, because that's important in terms of the scoring system. And we do a chest X-ray to look whether there's any metastases. If there are metastases on the chest X-ray or suspicion of it, we do a CT of the chest to confirm this and count them up, because that adds into the scoring system. And once you've got lung metastases, you are at increased risk of brain disease. So we do an MRI head. The vast majority of women will have no metastases when we see them. So what is the treatment? Very simple, methotrexate injections into the bottom on one day and a folinic acid tablet 30 hours later the next day. And you alternate between these two drugs for a week, and then you have a week off. and then you have another week of treatment and a week off until the HCG has been normal for 6 weeks. And the alternative to this very simple regime is to give actinomycin D intravenously once every 2 weeks. Either will work very well. In the UK, we've tended to prefer the upper regime, the methotrexate regime, because it's something that can easily be delivered in the home with a district nurse popping in to give an injection, rather than having to drag the patient up to a chemotherapy suite somewhere in the country. So this illustrates a lady who had her mole evacuated. This is her HCG on a logarithmic scale and time along the bottom. You can see the HCG following the molar evacuation is really very platted. It's going nowhere. So she was called up, she was scored, she was low risk, and she was started on methotrexate and folinic acid treatment. And you can see that her HCG fell to normal. Our normal is between 0 to 4. And of course, if you do a logarithmic scale, you can more clearly see what's happening at this low level. And then once it was normal, we gave 3 consolidation cycles of the treatment. Now in Holland, they only give 2 consolidation cycles. And so we did a comparative study with them and showed that their relapse rate was 8% on completion of treatment, whereas ours is only 4%, which has led most people now to give 3 consolidation cycles. Once the HCG hits normal, we estimate that there are about 100,000 cancer cells left. So to see a lump of cancer on a CT or a PET or an MRI, you need about 10 to the 7 tumor cells. So this is 2 logs more sensitive than any other kind of technique that we have available today. So this is really still the best cancer biomarker we have. All right, so how successful is this treatment? Well, this is an old analysis of 485 low-risk patients treated with methotrexate and folinic acid. And you can see that roughly 2/3 of those women normalized their HCG on that treatment. 1/3 became resistant during treatment to the methotrexate and folinic acid. And a small percentage developed toxicity to the methotrexate in the form of very severe mucositis or sharp pains in the chest and the tummy from a serositis. And so those patients that developed resistance or toxicity were switched to either receiving second single agent actinomycin D, if their HCG was 100 or less at the point of resistance or toxicity, or if the HCG was above 100, they went on to the combination agent chemotherapy regime. The bottom dollar is that there was 100% cure rate at the end, and actinomycin D as a single agent saved most of the patients from actually needing EMA-CO. So EMA-CO is a combination agent regime, much more toxic. You lose your hair, you're really quite unwell with it, much nicer to avoid it. So given that we had this great success, we thought, well, great, let's increase the HCG cutoff to 300 and see whether we could spare more people EMA-CO and still have 100% cure rate. And the answer is yes. So we then moved it up to 1,000 and once again showed that we could spare more people the EMA-CO. So that was good news and still had 100% cure rate. So this is a wonderful good news story. And we're currently piloting 3,000 as the cutoff. And I'm pretty sure I know we're going to show that the 100% cure rate is there and we're sparing more people EMA-CO. So fairly shortly, this is going to go up to 10,000. There are some centres in the world that do not bother to have a cutoff and just treat all methotrexate failures with actinomycin D. And interestingly, those centres are still reporting an occasional death in their series. So it perhaps isn't the best idea to give it to all and sundry, but we're taking a more conservative approach in the UK, as are most centres around the world. So what about the high-risk patients, the ones that are much more likely to become resistant to single-agent therapy? And you'll remember I made a distinction between regular high risk scoring 7 to 12 and the ultra high risk scoring 13 and above. What's that all about? Well, if you're regular high risk, there are no early deaths within the first 4 weeks of admission to hospital to get on with treatment. Whereas if you have ultra high risk disease, there is definitely a risk of early death within the first 4 weeks, usually from too rapid tumor collapse and bleeding or metabolic upset causing failure of organs. So there's also a risk of late death. So in the regular high risk, there's a very low risk of having late death from drug-resistant disease, whereas in the ultra high risk, there is a significant risk of late death from multi-drug resistant disease. So there is a difference in these groups, and there are some associated factors. So if your interval from the causative pregnancy is less than 2.8 years, you're more likely to be regular high risk. If it's more than 2.8 years from the causative pregnancy, you're more likely to be ultra high risk. And ultra high risk is associated with liver metastases, renal metastases, liver and brain metastases, and generally very advanced disease. So if your lungs are stuffed full of metastases, you're going to do badly if you don't treat them as ultra high risk. So how can we avoid the early deaths? Well, Alifrangus very nicely showed in the JCO paper in 2013 that if you start these patients on low-dose etoposide and cisplatin, rather than getting on with standard doses of EMA-co chemotherapy, that you avoid the massive hemorrhage and metabolic syndrome problems. So this gentle induction chemotherapy using etoposide 100 milligrams per meter squared and cisplatin 20 milligrams per meter squared on days 1 and 2, perhaps repeated weekly for 2 or 3 cycles if needed until the patient is more stable, is a way to completely avoid the early deaths. And others have now shown this. So the French group, for example, have shown this in 2016. So following that, if you've got ultra high risk disease, it's quite smart to consider how you're going to adapt the chemotherapy. Just continuing with EMA-co may not be the best for the patient, and adding in platinum-based treatment probably will help reduce the risk of late deaths from multi-drug resistant disease. So how does this high-risk disease present? Most of these cases are not following a molar pregnancy. These are patients who've had a pregnancy recently or some years ago and then present with metastatic disease. This patient went to her dentist. She'd had a baby 2 years earlier, and she went to her dentist with what she thought was an abscess in her gum. The dentist looked at this and said, I think you need to go and see an oral surgeon. I don't think this is an abscess. And as she got out of the chair, she actually fainted. So they called an ambulance. By the time the ambulance came, she was up and about and saying, I'm fine, I don't need to go to hospital. They said, no, you really ought to go to hospital because you fainted and we don't like the look of this thing in your gum. So anyway, so she went. And of course, when she arrived, what would they do? Somebody's had a collapse. Oh, we'll do an ECG and you probably need a chest x-ray. But before we do a chest x-ray, we'll do a pregnancy test. Her pregnancy test was positive. And then to cut a long story short, she was subsequently found to have brain metastases, lung metastases, the mets that you can see in the gum, liver metastases, renal metastases, nothing in the uterus. But the positive pregnancy test made them think, oh, could this be a choriocarcinoma? And so they very wisely got on the phone to us at Charing Cross, and we said, absolutely, send her straight down to us and we'll sort her out. And indeed, she got popped onto some chemotherapy, and you can see that the lesion in the gum has all gone away, all her other disease melted away, and she's made a full recovery and is now busy having some more kids, or in fact has had some more kids. So any woman of childbearing age with unexplained metastases, measure the HCG, you'll save someone's life. For heaven's sake, don't stick a needle into a liver metastasis. These things are so vascular, you just end up having them bleed to death on the end of the needle. So it follows from this that you're going to need quite a broad spectrum of investigations: CT, chest and abdomen with contrast, MRI, brain and pelvis, and if the brain's involved, the spine, because you could easily have spinal mets, all with contrast. Sometimes we get extra information by just doing a simple Doppler ultrasound of the pelvis that was missed on the MR, so we do that as well. If you suspect brain disease, but the brain is negative on scan, you might want to do a lumbar puncture to measure the CSF to serum HCG ratio, which should be less than 1 in 60. If it's more than that, you've got occult disease in the head. PET scans, people often ask me, should we do a CT PET? Not usually terribly helpful in the initial management, but could be helpful later on when you've got a relapsed patient with multiple disease sites. You're not sure which is the active lesion to try and remove surgically. So that can be a useful time to bring out your PET CT. Notice histopathology is not mandatory. Woman of childbearing age, raised HCG, multiple metastases. You could treat that patient on spec as a choriocarcinoma with curative intent rather than stick a needle into the liver. These days, we can actually now do circulating tumor DNA extraction to prove that the ctDNA contains DNA other than the patient's in them. So her partner's DNA, i.e. this is a gestational tumor. So genetics can be very helpful. And of course, if you've got tissue out, you can validate that the tumor is gestational as opposed to non-gestational using macrosatellite polymorphism analysis. So this is the chemotherapy regime that is used in regular high-risk disease. So this is EMA, etoposide, methotrexate and actinomycin D over 2 days. You give a repeat of the etoposide and actinomycin D on the second day. So that's an overnight stay in hospital. And a week later, the patient comes back for the cyclophosphamide and vincristine as an outpatient. So every 2 weeks, the patient has to have an overnight stay in hospital. And they need GCSF support each week to maintain the treatment intensity. Obviously, you're going to lose your hair on this, unlike with single agent methotrexate, and just a little bit of hair thinning with actinomycin D. So this is more toxic for patients in a variety of different ways, including the myelosuppression. So it works, and this is the proof of the pudding. So this is an analysis that we published in 2013. That's that Alifrangus paper I mentioned to you earlier. And these are all the high-risk patients, regular high risk and ultra high risk, all lumped together. And you can see that we get a nice long-term survival running at around 94% in this analysis. I can tell you today, the survival is closer to 98% because of immunotherapy that we'll be talking about shortly. And these are the non-gestational cancers, so the ones that we thought might turn out to be a pregnancy-related choriocarcinoma. But then when we got genetics back, we discovered they were in fact a lung cancer that had turned on HCG production, or a stomach cancer, or a breast cancer that had turned on HCG production. Remember, all cancers are genetically unstable, and so they can turn on the right constellation of genes to produce HCG, and even to look just like a choriocarcinoma under the microscope, even though they're not. The top line is the low-risk patients who switched to EMA-CO. And you remember I said 100% survival, but on this line, you'll notice that there's a death here at about 7.5 years. That is nothing to do with the disease. This was a patient who couldn't give up the fags and unfortunately developed lung cancer and died from lung cancer. So, all right. do we cure everybody with Emico, or does this survival curve that you're looking at here require some other things for some patients? And of course, the answer is it does require some other things for some people. About 20% of patients will either relapse after Emico, or will develop primary resistance during Emico and need additional treatment. So how do we salvage them? So there are a number of different approaches. There's a platinum-based etoposide and platinum alternating with EMA regime, very active but horribly toxic. So we made a less toxic and equally active Taxol and etoposide alternating every 2 weeks with Taxol and cisplatin. Both of these salvage about 75 to 80% of the EMA-CO failures. But as I said, TETP is much less toxic. What about high-dose chemotherapy? You'll remember that high dose is used a lot in management of leukemias and lymphomas. Could it be useful in this very aggressive and fast-growing tumor? And the answer is yes, it can help, but it is horribly toxic, and we've now got something much better. There are a number of other drugs that have been tried. Surgery should not be forgotten. Chopping out isolated foci of drug-resistant disease can clearly be curative in selected cases. Radiotherapy, I haven't said very much about that, and the reason for that is that I've never cured a patient solely with radiotherapy. It can be helpful, though, if you've got a deep-seated lesion in the head that's still present after chemotherapy. So you can give some stereotactic radiotherapy to that lesion, and that may prevent the recurrence. Seems to work. We avoid whole brain radiotherapy, unlike some of our colleagues in the rest of the world who seem to like frying women's brains, young women's brains. I really hate the idea, because these women live for decades and decades, and of course radiotherapy adds to the toxicity. So we have avoided it. And in fact, if you compare the non-randomized data where they've given radiotherapy whole brain or they haven't from various centers, the data look exactly the same. So it doesn't really look like the whole brain radiotherapy adds anything to the overall survival. What about new agents? Well, these tumors do have EGFR on them, but they're not mutant. And doesn't seem the EGFR targeting agents don't seem to work. Antivascular agents, we've tried them and not been terribly successful. There are other things you could envisage using. There's one case who responded to anti-endoglin, but I really want to get on and talk to you about the immune checkpoint inhibitors, because this is really revolutionizing the management of these patients. It's an example of how wonderful immunotherapy can really be. So this is a patient who presented with ultra-high risk disease. So when she arrived, she had disease in her brain, in her liver, in her lungs, again, not in the uterus. About a third of these cases who present with high risk or ultra-high risk disease don't have anything left in the uterus. That disease has burnt out or just moved on. So she started on the low-dose etoposide and cisplatin, so we didn't kill her within the first week or two of her admission. And then she got on to the EMA chemotherapy because she had such nasty disease. We didn't get on with EMA-CO, and we adapted the EMA because of her brain disease to give her 1 gram per meter squared of methotrexate rather than the 300 milligrams per meter squared. And you can see she had a great response. She goes into remission. Fabulous, except not fabulous because she relapses, as you can see here. So she was then treated with Taxol and etoposide alternating with Taxol and cisplatin. And she responds to this, and we follow that with a tandem transplant. So she goes through high-dose chemotherapy, really horrid, and she gets out of that, and she's in remission. Wonderful, except no, she relapses. So, and at this point, we take out one of her lung lesions, and it's choriocarcinoma. And we get on with escalated etoposide and cisplatin. It's 500 mg per meter squared of etoposide and 60 mg per meter squared of cisplatin, all on day 1, repeated every 2 weeks. She gets a partial response and then gets resistant. We put her onto GemTip, which is a germ cell tumor regime, and she doesn't really respond to that. And at this point, this lady is doomed. I mean, there's no surgery to cure her. She's got metastatic disease in lots of places. So what do we do? Well, trophoblastic disease, 50% at least of the genome is foreign. It comes from the father. So we should be able to get the immune system to reject it, shouldn't we? Well, we've tried pembrolizumab. We got this from a charity for the patient. And you'll see she had a very lovely response to the pembrolizumab with normalization of her HCG. And after 5 consolidation cycles, we ran out of money, so we just stopped and watched. And she did very well. So is this just anecdote, or is there something more to this? So we've set up a multi-center international collaboration looking at giving pembrolizumab to these patients. You'll see that 22 have had it now in the UK, but we've got a number of cases from around the globe. So total of 58 patients treated with pembrolizumab. And of those 58, 47 so had disease that was it's 59, isn't it? 47 had a disease that was in the measurable range, like the patient I've just shown you, multiply failed treatment. And you'll see that the complete response rate was 70%. And this includes patients with placental site trophoblastic and epithelioid trophoblastic tumors, which are harder to achieve long-term remission in. And 11 of 12 patients received treatment adjuvantly for poor risk disease after stuff had been removed. And 11 of those 12 patients remain in remission. And most of these are poor risk placental site trophoblastic and epithelioid trophoblastic tumors, which we'll talk about shortly. So that's good, but the median follow-up is still quite short. Do we have any predictors of response? And the answer is no, they're all PD-L1 positive. They all express PD-L1, so that's useless. There's no mutational burden in these tumors. If you sequence the hell out of them, you'll find that the choriocarcinoma is a desert. There's just no mutations going on in chorio of any significance. There are a few that happen in ETT and PSTT, so that's a little bit different. But effectively, if you're looking at your mutational burden as a way to select patients, forget it. There may be something about HLA-G expression and whether that might correlate with predicting who responds and who doesn't. But it's a massive response rate compared to any other tumor for a single-use immunotherapy. Right, so should we be using immunotherapy earlier in the disease course? So this French study set out to see whether we should give a different agent. So this one, avelumab, targets programmed F ligand 1, so not the T cell receptor, but the ligand on the trophoblast. And you'll see that they took patients who'd become resistant to one single agent therapy. They didn't bother to give them a second single agent, but gave them instead avelumab. And you'll see that the response rate to that is around 50 or 53% or so. It's not massive and certainly not as good as you would have expected with single agent actinomycin D. So seems like you're using a sledgehammer here, perhaps to crack open a nut, and very expensive. In the high risk population, they took patients who had failed either EMA-CO or EMA-EP if they'd had that as their first line treatment. So not waiting for a further line of treatment failure before trying the immunotherapy. And very disappointingly, they had to close this arm of their study down early after 7 patients because of futility. Basically, patients were progressing and not doing well. So is this because avelumab behaves differently from pembrolizumab? Is it because this is a different patient setting? Lots of unanswered questions. lots more work required. What's the long-term outlook in these patients treated with low risk or high risk treatment? Very good. 4% overall relapse rate after they've gone into remission. The important thing is 83% of these women go on to have successful pregnancies afterwards, whether they had the single agent treatment or the combination agent chemotherapy, which I think is a wonderful good news story for these young women. We do know that the combination agent chemotherapy hastens the menopause by 3 years. There's no increased risk of second cancers, interestingly enough, if you keep this treatment to under 6 months total duration. We advise our patients not to get pregnant for a year after completing their chemotherapy. 500 of them have already ignored this advice and got pregnant in that first year. And interestingly, there was no increase in the abnormal fetus rate, so no increase in the relapse rate, and no increase in having miscarriages. So it looks like it's actually pretty safe to get pregnant in that first year. So in summary for this bit, 16% of complete moles, 1% of partial moles will end up needing chemotherapy. What's been so effective in the UK is a centralized registration process for all women with molar pregnancies and other forms of trophoblastic disease with centralized pathology review, because we change the diagnosis in between 10 to 30% of cases, sometimes deregistering patients and sometimes registering patients who were thought not to need it. HCG monitoring has been completely essential for the success of our service. Low-risk patients can now expect 100% survival, whereas 70 years ago, all of them died. High risk, we're way in excess of 94% survival. Ultra-high risk needs careful modification of the treatment, as we discussed. Salvage treatment with surgery certainly can be helpful, but immunotherapy now really looks like the way ahead, much better than a nasty, toxic, high-dose chemotherapy. Fertility outcomes are excellent. We can now stop the HCG monitoring. We stop now in the UK after 10 years, but a lot of countries now stop after 1 or 2 years. That's probably a bit too early because most of the relapses will have happened in the first 3 years. So what about placental-sized and epithelioid trophoblastic tumours? Well, compared to choreo, they're much more slow growing. They metastasize much later in their natural history. Lymph node involvement is actually a bit more common. It's pretty rare in choreo. It's a bit less chemosensitive than choriocarcinoma. And it arises rather from the syncytial trophoblast. It actually comes out of the intermediate trophoblast. It secretes much less HCG in many cases. And in fact, in some cases, there's no HCG secretion. So there, the biomarker that we were talking about earlier is not so useful. And the overall survival rate is less. So is there some way of predicting who's going to do well and do badly? And the answer is yes. If you present more than 48 months out from the end of the causative or presumed causative pregnancy, then you do very badly. Whereas if you present within 48 months, you do extremely well, regardless of stage. On the other hand, stage does add something to this dynamic. It is an independent prognostic factor. And particularly if you've got stage 4 disease, even if you present within 48 months, you do badly. So knowing this means that we can adapt our treatments and treat these patients much more aggressively. So if you're more than 48 months and you've got stage 1 disease all confined to the uterus, you treat that one very aggressively after a hysterectomy. So you don't just rely on the hysterectomy to do the job. So this just summarizes how we manage these patients, because I don't have much time to go into detail. Diagnosis, here pathology really is essential. You can't just diagnose it on an HCG test or on the circulating tumor DNA. You actually need tissue out. So the prognostic markers we've talked about, There are others that may turn out to be relevant as our data sets enlarge. Might be that the mitotic index could turn out to be another independent prognostic factor, but it isn't at the moment. And the current recommended treatment, if you've got local disease, hysterectomy, much more so than focal resections. We've tried focal resections, others have tried it. It may work in selected cases. The problem is, we know that in some women, you've got microscopic bits of this disease scattered through the uterus that you can't see on imaging. And if you do a focal resection of the obvious lump, you may be missing all these other things and storing up problems for later. Metastatic disease, we prefer platinum-containing regimes like ep-ema and resect residual lesions. If you're more than 48 months or stage 4, it's ep-ema followed by immunotherapy. We've given up on high dose because it's just so toxic and not as good as immunotherapy. So I think I'm going to stop there and thank the whole group of people that I work with in Charing Cross in the UK and abroad. And if you want further information, please don't hesitate to email me. Our website, you'll find, is full of information that is useful to you, as well as some source references. So, yeah, I'm going to back off here.
Oh, brilliant. Thanks very much, Prof. Seckl. That was really interesting, particularly some of the newer treatments and I guess some of the advances. I can't see any questions at the moment on the chat, unless anyone wants a question just for the time being. I know that it is 10 minutes past when we were scheduled to finish, but obviously we had some technical problems at the start. We do have a case presentation from Tom Talbot, who's one of the registrars in London, and Tom's kindly agreed to try and keep this nice and brief, just to highlight a case where that 48-month cutoff is really important. So if you have any questions, just pop them in the chat. But in the meantime, I'll hand over to Tom for his case presentation.
Thank you very much, Richard, and thank you to ACP for having me. I realise I am imposing on people's dinners, so I shall keep it as brief as possible and try to avoid duplicating what Prof has already detailed in such a crisp manner. I'm going to talk about epithelioid trophoblastic tumour, a case of that specifically with an attempt at wit in the title. Size doesn't matter. So ETT Prof has already talked about, and just to sort of stress that we've only clocked about 180 cases in history ever, at least with histopathological confirmation. So we're talking a very, very rare cancer indeed. Don't be afraid if you've not heard of it prior to today. That bit is irrelevant. And yes, to reiterate, there's a 10 to 15% lifetime risk of atypical placental site nodules developing it. So we do offer surveillance or hysterectomy to women presenting to our service with atypical placental site nodules. It makes less HCG than choreo, and treatment for the disease is multimodality, and that includes surgery for both primary disease as well as any metastases, in combination with some quite toxic chemotherapy and immunotherapy. It is sensitive, but not as sensitive as choriocarcinoma. Enjoys a bit of cisplatin, enjoys high doses of methotrexate intravenously as well. And it also responds to immunotherapy, as Prof. Seckl was already illustrating. And that is becoming part of standard of care for high-risk ETT and PSTT patients. And the key feature here, which is true of all gestational trophoblastic disease, but has a particularly striking truth in ETT, PSTT, is that if the causative pregnancy for the ETT was more than 4 years prior to its emergence or its diagnosis, the survival for the disease is significantly poorer. So here's an OS curve from a 2009 study. Survival is better. This is for ETT and PSTTs, very similar behavior of disease, similar features as well genetically. And this is the same cohort of patients if you separate them by whether they have an above 4 year or below 4 year interval. Above 4 years is that red line at the bottom, and below is the blue line at the top. So really dramatic separation of the curves. And all women in this study by 5.5 years in that poorest group had died. Things have changed, things are better. So the hashed blue line is from the previous study, This 2019 study from Froling includes a new cohort. With the benefit of that knowledge, you can see that we are reaching, as of that era, survival in about 30-35% of women. It is now better. What have we changed? Well, we're giving more chemotherapy overall, and EPEMA happens to be one of our favorite regimes, nice and toxic, as Prof was describing. We're using TETP, which is also alluded to earlier. That's less toxic, more neuropathy with lots of paclitaxel. Get neuropathy with both, but it's a good salvage option as well. More high-dose chemotherapy, it's awful, but there's still a niche for this. And we are using less EMA-CO. EMA-CO is close to our hearts for choriocarcinomas and high-risk GTD of the non-ETT PST types, but it's fallen out of favor for ETT PSTT. So onto the case. We've got a 46-year-old lady with no significant medical history. She presented in 2018 with pelvic pain and PV bleeding. She had also had prior pelvic inflammatory disease related to a coil, and she had either 3 or 4 pregnancies. There was a possible miscarriage more recently. She had 2 children. Investigations-wise, fibroids and ultrasound and a normal hysteroscopy. She goes ahead with a hysterectomy. She's completed her family, indications being the fibroids, bleeding, and the prior PID. And voila, it crops up an incredibly rare tumor, a very small one, which is pathologically stage 1A. It's an epithelioid trophoblastic tumor. Total surprise. She's scanned very thoroughly, MRI of the head, abdomen, and pelvis, all with contrast, and a CT of chest also with contrast. So she's stage 1A by the sort of more conventional staging criteria that we would use for gynecological cancers. We used short tandem repeat genotyping, and we've got a genetic service at Charing Cross. And that shows this ECT has come from a baby that was born in 2001, or a pregnancy with a baby born in 2001. So she's got a 17, 18 year interval, and she's clearly very, very high risk based on that, but very early stage. Knowing what happens to these women, she's offered adjuvant chemotherapy plus or minus pembro immunotherapy, more of an experimental basis, using that in the first instance to spare the toxicity of combination chemotherapy. And quite understandably, she declines treatment as there's no cancer left. Perhaps she's not read one of these papers. And she goes on to surveillance, which is MRI of the abdomen and pelvis plus HCG. You can't rely on one alone. And this is what happens. So for 2 years, she's very well. I don't think I've got my pointer working at the moment, so I'll let you read things across the bottom. On the left, we've got HCG. She's completely happy for 2 years, and then her HCG starts rising. This lady is not pregnant. She hasn't got a uterus. So something else is making that HCG. She has staging scans where nothing is visible. So she's a biochemical only relapse. We cannot do nothing about this. She will eventually die of this disease if we don't treat it. So she has EPEMA, our favorite ETT combination chemotherapy, with a very rapid normalization of HCG, followed by consolidation pembro. There is a little pause there, which was for peripheral neuropathy, and that was eventually deemed delayed onset chemotherapy related rather than immuno. Proceeds, remains on treatment, very nearly finished, doing fantastically well. So this all, I'll try and skip over a few slides because we are really running out of time, but this all sort of ties into who needs adjuvant treatment. There's various things that, one of the biggest oncology questions we have, even if you've got your R0 margins, low volume of disease, not a guarantee of cure. We can't detect micrometastases in circulating cancer cells. At least for ETT, it's different. We know we can recommend adjuvant treatment on more than just stage. Richard, feel free to stop me whenever anyone's gone for dinner. If you look at the hazard ratio from that same study in 2019, you can see a massively increased risk. The long and short of this is that when you do the multivariate analysis, you can confirm actually that stage 4 disease is also an independent predictor of poor prognosis, as you might not be surprised to see if you transpose the rest of oncology to this disease. And if you look at these two separate plots, which I think Prof also showed you, stage 1 disease, obviously a very big separation of the curves there, but you do also see deaths in women with good risk based on pregnancy interval, but stage 4 disease as well. So we'll qualify and we'll say that size doesn't always matter because stage 4 disease is also an independent prognostic factor. Have I got a minute or two to stop me whenever? High-dose chemotherapy, I think of it as a tactical nuke. It cures about 20% of poor-risk ETTs, PSTTs, but kills a fair few patients along the way with allogeneic bone marrow transplants as well. It's carboplatin and etoposide. We like to throw in cyclophosphamide and paclitaxel as well. Immunotherapy is really revolutionizing this disease. Turns off the immune off switch. We, as Prof has already said, I'll sort of skip over that. The complete response rate is 72%, which is absolutely fantastic. Getting this drug was very difficult. We can't do randomized trials. It's far too rare for that. And this is now sort of forming standard of care, but it's via charitable access. Hopefully one day it will get a full license and funding. Why does it work? Prof talked about some biomarkers. We're trying to find out why it works in some women and doesn't in others. It's got very high expression of PD-L1, much like the placental tissue that it resembles. Low MHC class 1, some potential biomarkers therein. But whatever is being expressed contains a lot of paternal DNA, so there should be some neoantigens there that we can generate an immune response with Pembro. And similar curve to the one you saw before. This is a lady who'd gone through an awful lot of very nasty treatment, not quite normalized her HCG at the end, and has grade 3 neuropathy at this point, one of the earliest women we treated with Pembro. She's not a candidate for high-dose chemotherapy because of her toxicity. And in comes our new old favorite, pembrolizumab. A little bit of an upstroke with the HCG initially as that immunity is generated, followed by normalization, and this lady, I believe, remains in remission to this day. So to conclude, a slightly rapid presentation, we've talked about that poorer prognosis interval if it's more than 4 years. That has allowed us to recommend adjuvant treatment, even in stage 1 patients, if they're high risk. Immunotherapy is smashing, we love it. It should work for everything. It's unfortunate that it doesn't, but it's certainly less toxic than high-dose chemotherapy and more effective for this disease. Lots of questions that we still need to answer. We're working on these. Can we drop chemo and just give immuno, spare lots of toxicity? Why does it not work in some women? Prof was alluding to that earlier. What happens at 48 months? What are the genetic or epigenetic or immune events that occur at that point in time? Why is it so key? Are all immunotherapies the same? I've seen some evidence to suggest that avelumab as a PD-L1 targeter rather than a PD-1 targeter doesn't seem to be equal, but that's slightly extrapolative. Can we combine it with chemo like we like to do for non-small cell lung cancer? Many, many more, and that's everything. Thank you very much.
I can't see any questions in the chat, but I do have one question for the two of you. You mentioned that in terms of genetics here, you sort of do some sequencing. Obviously, for some of these cancers, correct me if I'm wrong in my understanding, but some of the DNA can be paternal. Have you ever picked up any mutations from the paternal DNA? And in that case, is there any sort of problem with the ethics of testing these when potentially you may not have the father's consent for that?
Yeah, so you're quite right, Richard, that we do need the dad's consent. But the answer is it's basically a mutational desert. So if you do the epigenome, however, you find that it's quite interesting that in the choriocarcinomas seem to look like very early aggressive invasive placenta at the epigenome level. So I suspect we're going to find that there's a lot more epigenetic changes that govern the tumorigenic process rather than mutational changes. That's certainly true for chorio. What will be the case for ETT and PSTT is, I don't know yet. Got a PhD student working very hard on the difference between what happens at 48 months and less than 48 months, and it's watch this space.
But have you ever picked up any sort of germline mutations that may not be contributing to the cancer? But
yeah, you're right, we might turn those up. We haven't so far, but yeah, you're right. And of course the mother and the patient and her partner have to agree to provide their material for us to do the work, and that's what they're doing.
It's a bit of a new dynamic that we don't often have to worry about for most of our patients.
Yeah, true.
I can't see any other questions on the chat, but I mean, I know that obviously we are running a bit behind, but
We're all tired. Everybody wants to go and have some supper, I think.
I'm sure pancakes, given that it's pancake day today. So, but I personally, I've really appreciated all the talks. I've learned a lot from that. So thanks everyone for giving your time and presenting today. For the people that are still watching, these presentations are uploaded to the website, so you can access them at any time. I think I'd like to just say thanks to all our presenters, and hope you enjoy the rest of your evening.
Yeah, brilliant. Thanks.
Thank you.
Bye,
Bye-bye.
everybody. Bye. Bye.
Thank you. Bye.